So on page 205, at the top, so we were learning near the end of class last time that we can divide the cardiac cycle into 4 phases. First, we divide the cardiac cycle into 2 major phases, systole and diastole. What's systole again? The period where the ventricles contract. What's diastole? That's the period when the ventricles relax. Then each of those, systole and diastole, we further subdivide into 2 phases, each one. For systole, we had already learned this back on page 176. We divided systole into isovolumetric contraction phase of systole and ejection phase of systole. And we actually had nice pictures of this. So I want to refer you that anytime you're confused, you refer back to our pictures on 176, which look like this. So you can remind yourself of what's occurring during isovolumetric contraction phase of systole and what's occurring during ejection phase of systole. Now, we also divide diastole into 2 phases. Isovolumetric relaxation phase of diastole and filling phase of diastole. On our pictures on 176, I only showed you a picture of the filling phase, but not isovolumetric relaxation phase. But I will be explaining that today, and that's part of the question you had on that study guide. Okay, so let's try to explain this by looking at page 206. Now, as I mentioned to you previously, all of this is in your book, and there's also a lot of videos that we've linked that you can watch it. It may be useful. You know, I'm recording the lecture. We'll try to get it uploaded and all that. But you know what? Reading books are healthy. They're good for your health. And all of this is in the book, no matter which book you've got. All right, this is the diagram, and you can see it's in color. I showed you this last time. So it's showing you the phases of the cardiac cycle, and it's showing you all these changes. So what I'm covering is not esoteric information that is found only uniquely in Professor Fink physiology class. This is standard information that you learn in any physiology course. So the picture, the diagram that I've included on page 206, let's go over it and see if we can understand this. So this is kind of where we ended last time, but it's okay, I'll remind you of what's going on. Starting at the very bottom of 206, so what it shows here is that this is on the x-axis time going by, and it's showing 0.8 seconds in time. And that immediately reminds us that a normal cardiac cycle, when the heart rate is 75 beats a minute, each cardiac cycle or heartbeat lasts 0.8 of a second. 0.3 for systole, 0.5 for diastole. So that's what the 0.8 of a second is. That's a cardiac cycle. What it shows on the first trace or graph is the electrocardiogram, specifically lead 2, which is the only electrocardiographic lead that we've tried to really explain to you. And so on lead 2, there are 3 waves. There are not necessarily 3 waves on every electrocardiographic lead. They are different views of how the electrical current is flowing through the heart. But lead 2 is the most important one, as we've explained previously. The first wave, the P wave, represents atrial depolarization. The second wave, the QRS, represents ventricular depolarization. And the third wave represents ventricular repolarization. Why isn't there a wave for atrial repolarization? Because it occurs at the same time that the ventricles depolarize. We covered that previously. Now, in the second trace, it's showing the volume of blood in the ventricle. Now, this is specifically the left ventricle, but normally the volume of blood in both ventricles, right and left, both normally fill at the same time, and they fill up with the same volume and eject the same volume. If they're working properly, they are working together, doing exactly the same thing. However, if you have left-sided failure, then the left side isn't doing what the right side is doing, so then they may not match. But this is specifically the left, but the right should be doing the same thing. Here it shows that the ventricle fills to 120 milliliters of blood. That's called the end diastolic volume. Here it's ejecting blood. The volume in the ventricle is decreasing. That's called the stroke volume, and it ejects typically 70 milliliters of blood each time it contracts. But it still leaves 50 milliliters of blood in the ventricle at the end of systole. That's called the end systolic volume. And here it's refilling back up to 120. We'll come back to all this in a moment. In the next trace, it's showing the lub-dup, lub-dup. The lub sound is caused by closing of the AV valves. The second heart sound, the dup sound, is caused by, right up here, closing of the aortic valve. And also the pulmonary valve. They're normally at the same time. We had learned that valves normally only make a noise when they shut. They normally open silently. There's no noise normally when they open, only when they close. So that's what you should know what the lub and dup sounds are. Now, this solid black line right here is showing the change in pressure. Now, this is specifically only in the left ventricle. The right ventricle, we will show you. We will compare the pressures generated in the right ventricle with those in the left, and they are really about 1/6 the pressure in the right ventricle than they are in the left. The left ventricle generates 6 times greater pressure. It works 6 times harder than the right ventricle. What is the range of pressures in the left ventricle? It ranges from 0, which means atmospheric, all the way up to a high of 120, approximately. And then it goes all the way back down to 0, or atmospheric. So literally, the blood pressure in the left ventricle would be written as 120/0. When it contracts, it goes up to 120. When it relaxes, it drops totally to atmospheric. Now, the last line here, in the dashed line, is the blood pressure in the aorta. The left ventricle ejects blood out into the aorta. And so the blood pressure in the aorta ranges from a high of 120 to a low of about 80, approximately. So we would write that the aortic blood pressure is 120/80. All right, at the top, it shows those 4 phases that we've mentioned. The 2 phases of systole and the 2 phases of diastole. Now, before I walk you through this graph, I want to try to give you a visual of this. And I don't know, I'll try videotaping this. This isn't going to show up very well. We're going to use this room to help us understand what the heart is doing. Let's pretend that this room that we're sitting in is the left ventricle. We're literally in the left ventricle. Now, we need an inlet valve and an outlet valve. Now, first of all, what's the name of the inlet valve that allows blood into the left ventricle? The left AV valve, also known by anatomists as the, clinicians call it the mitral, anatomists call it the bicuspid. That's old information, you still got to know it, all right? So, we need a bicuspid valve or left AV valve. We're going to call this cabinet right here, all right? And look at, isn't this nice? It's got 2 cusps. You know what it took to design a room so it would work like this? All right, so this is our left AV valve. It's a bicuspid valve, 2 flaps, also known as the mitral valve. So right now, when this valve is open, blood in the left atrium is flowing into this room, the left ventricle. Now we need an outlet valve. So we're going to make the outlet valve way over here. And what is the name of the valve that the left ventricle ejects blood out? This is the aortic valve. Now this is basic information. If you get confused by this, you haven't memorized how blood flows through the most, at least the first, certainly the second most important organ in the body, the heart. So this is our aortic valve, our outlet valve. So literally the job of the heart here in the left pump is blood goes from the left atrium into this room, the left ventricle, and from the left ventricle it's ejected out here into the aorta. I'm in the aorta right now. Now that we've got a visual aid, which we can use when we answer questions on the exam. And incidentally, if you're taking a board exam, all you need to do, whatever room you're in, look at two doors, find two doors, pretend one door is the inlet and the other is the outlet as a visual aid. Now, let's imagine an electrical current is flowing right now through the walls and ceiling of this room. As the electrical current is flowing through, and notice these cells are electrically joined together by intercalated discs or gap junctions. All right? So literally, as this electrical current flows from one cell to the next, the walls of this room are going to start to come in on us. All right? Now, there's about 120 milliliters of blood in this room. As the walls start to come in on us, what's going to happen to the pressure inside this room? In the left ventricle, it's going to start to rise. Now, look what happens back here. As the pressure starts to rise in this room, isn't the blood going to start to go backwards? Right? As the pressure is increasing in this room. As the blood starts to flow backwards, that's what causes the AV valve to shut. Literally, the blood trying to go backwards closes the AV valve, or bicuspid valve. And as the pressure gets higher and higher, it simply keeps the valve shut even more forcefully. The harder I push, the more I effectively close that valve and prevent the blood from going backwards. If this left AV valve were insufficient, if it didn't shut all the way, then the blood would start, that means this valve didn't shut all the way, and blood would start to regurgitate backwards, creating a murmur during systole, during the time the ventricle is contracting. But we're going to assume it is working, and that closing of the AV valve is the first heart sound, the lump. Now, the pressure is building up. Notice, this inlet valve has been forced shut, the outlet valve is shut, no blood is entering this room, no blood is leaving this room, and the pressure is increasing. You know what we call this period? Isovolumetric contraction phase of systole. The volume is staying the same, but the pressure is building up. As I've just pointed out, the higher the pressure gets in this room, it simply forces that valve to stay shut. But as the pressure increases in this room, 20 millimeters, 30 millimeters, 40 millimeters, 50 millimeters, 60, 70, 75, when it reaches to about 70 or 80, it pushes this aortic valve open. And as this valve is forced open by the higher and higher pressure in this room, that causes ejection. So once this valve is forced open, we get ejection of blood. And the ventricle is going to eject about 70 milliliters of blood. That's called the stroke volume. Now, eventually, the ventricle is going to start to relax. And what's going to cause it to relax? The timing of relaxation is the repolarization in the ventricle. Because we know that it takes about 300 milliseconds for that action potential, and around the same time that it repolarizes, the ventricle starts to relax. And now let's imagine that the pressure in this room is starting to go down. As the pressure in this room, as the walls of the ventricle are relaxing and the pressure is dropping, the blood here in the aorta is going to try to flow backwards. As it flows backwards, it shuts that valve, the outlet valve. The shutting of the outlet valve creates the second heart sound, the DUP sound. DUP is created by closing of the outlet valve, the aortic and pulmonary valve. So literally, the time between the closing of the AV valve, the inlet valve, and the timing of the closing of the outlet valve was 0.3 of a second. That's the time that its systole lasts. Systole began with the closing of the AV valve. It ends with the closing of the outlet or aortic valve. 0.3 of a second. Now, now we're going to mention this fourth phase that we hadn't mentioned before. The pressure in this room is going to drop very dramatically. It's going to go from that high of 120 down to 0, atmospheric. And so during this time that the walls of the ventricle are relaxing and the pressure is dropping in this room, again, no more blood is going out, no blood is yet coming in. This is called isovolumetric relaxation phase as the pressure in this room drops. Now, we had said that as long as there was a high pressure in this room, the high pressure in this room was keeping this valve shut. But when the pressure in this room drops to atmospheric, that takes away this pressure against this valve, and this valve opens. And when that AV valve opens, the blood starts rushing into this room, and that's called the filling phase of diastole. So the filling phase is when the ventricle starts refilling back up with blood. All right, you got the visual. All right, now let's see how it appears on the graphs. On the graphs, I want to begin with the QRS wave. The QRS is associated with depolarization of the ventricles, right? So let's just look at the R wave, follow the R wave up, and how much blood is in the ventricle at the time of this QRS wave? How much blood is here? 120 milliliters of blood. So when the ventricle, when this electrical current starts to flow through the walls of the ventricle, there's 120 milliliters of blood in the ventricle. And look what happens. Watch the pressure. Look at this solid black line. And look what happens to the pressure in this room. Can you see that the pressure is going higher and higher and higher? Now, during this time where the pressure is going up, but the volume is staying the same, this is called isovolumetric contraction phase of systole. It means what it says. Isovolumetric, same volume. All that's happening, and incidentally, you'll notice what was the event that occurred at the very beginning of isovolumetric contraction phase? This AV valve shut. It was forced shut. The increasing pressure in this room forced that valve shut, creating the first heart sound, the lub. And the pressure increases 20, 30, 40, 50, 60, 65, 70, 80. Remember, the higher the pressure gets, it keeps that valve shut. But as the pressure rises, when it gets to be about 70, 75, 80 millimeters of mercury, that pushes that aortic valve open. No noise when a valve opens, but that begins the ejection phase. So you'll notice that right here, when it reaches about 75, 80, 85 millimeters of mercury, that aortic valve is forced open. And that begins the ejection phase, right here. The blood is being ejected. Let's see that. Can everybody see? Look what happens to the volume in the ventricle right here. It's going down. The ventricle is ejecting blood. How much is it going to eject? 70 milliliters with every stroke of my heart, right? 70 milliliters is going to eject. That's the stroke volume. Now, notice that let's show you something else. The pressure in this ventricle is going to rise all the way up to a high of 120 during the ejection. Now, I'm in the aorta out here in the hallway. When this door is open, whatever the pressure is in the left ventricle, that's what the pressure is in the aorta. They are like one room because there's an opening between them. So whatever the pressure is here, that's what the pressure is where I am in this hall. So if it reaches 120 where you are, it's going to be 120 where I am in the aorta. Does everybody follow that? And you can see that on the graph. In the dashed line represents the pressure in the aorta. Once that aortic valve opens, whatever the solid black line is, that's what the dashed line is. Whatever the pressure in the left ventricle is, that's what the pressure in the aorta is. So now you know what determines your systolic arterial blood pressure. If your systolic arterial blood pressure is 120, it's 120 because your left ventricle generates a high peak pressure of 120. What if you take your blood pressure and your systolic high is 110? Then that means your left ventricle peaks at 110. What if you take your blood pressure and you have a systolic high of 170? That means your left ventricle peaks at 170. That's why it's called the systolic blood pressure. It is created by systole, by the ventricles contracting. They are what create that systolic high. Does everybody follow that? That's important. Now, when the ventricle starts to relax, the blood's going to start to try to come backwards, which is going to shut this door. If this door is insufficient, if it doesn't shut all the way, blood will start to regurgitate backwards, right back into the left ventricle where it came from. That's not supposed to happen, and that'll create a murmur during diastole. But normally it should shut. Let's just show you how this works. Now, you'll notice that it reached a high of 120, and interestingly, the pressure started to drop. But the ejection phase technically does not end until that aortic valve shuts. Now, why did the pressure start to go down even before that aortic valve shut? We can explain that by looking down at the electrocardiogram. Look at the T wave. What does the T wave represent? Ventricular repolarization. The ventricles are repolarizing. What I'd like you to do is follow this vertical line that goes right through the top, middle of the T wave. Follow it all the way up. Here it is. Here's that line. Let's follow it up, 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 up. Ooh! As the ventricles repolarize, they start to relax. And that's what's causing that pressure to start to drop. So it's the repolarization of the ventricles, which leads to relaxation of the ventricles. And as the ventricle wall starts to relax, the pressure inside the ventricle starts to go down. But the ejection phase technically does not end until the aortic valve shuts. And that shutting of the aortic valve creates the second heart sound right here. That's the dump sound. Now, look at what happens to the blood pressure. Can you see it just dropping precipitously? 110, 190, 80, 70, 60, 50, 40, heading to zero. This is called isovolumetric relaxation. It is exactly the reverse of isovolumetric contraction. In both cases, the inlet and outlet valves are shut, so no blood's entering and no blood's leaving. The only difference between isovolumetric contraction phase and isovolumetric relaxation phase is that in contraction phase the pressure is increasing, and in relaxation the pressure is decreasing. But in both cases, all the valves are shut, inlet and outlet. Now, as we said, when the pressure in this room has dropped essentially down to atmospheric, that takes away this pressure against this door, this cabinet, and now this door can open. And during this whole time that the ventricle has been busy contracting, the atria has been receiving this incoming blood. And since it's the left atrium, it's been receiving blood through the 4 pulmonary veins from the lungs. All this oxygenated blood has been flowing to the left atrium during this whole time that the left ventricle has been busy contracting. So now all this blood rushes in when this AV valve opens. And look at this, right after that AV valve opens, look at this line. The ventricle refills up with blood very rapidly. That's called the filling phase of diastole, the filling phase. What I'm trying to do, and again, you can look at your book as well and watch also some videos, is we're trying to walk you through. These graphs are simply a way of depicting these changes in what the heart is doing with respect to pressure and volumes. And what's actually leading all this is the electrical changes, because it is the wave of depolarization that leads to contraction and the wave of repolarization that leads to relaxation. So the electrical changes lead to the contractile changes, which lead to the volume changes. And that's what all this graph is showing. Now again, you can see in your book, they go step by step by step. What happens during a systole, ventricular systole, step by step, and the relaxation period, and they take you step by step, numbered, just looking at it. So that's what I've tried to do. If you get a handle on this, you really understand the heart. You understand the electrocardiogram and the electrical changes in the heart. You understand the heart sounds, the lub dup, and what's creating them. You understand the volumes of blood that the ventricles are filling up with and ejecting, and you understand the pressures that are created. I want to look at one more facet of the pressure. So we know that when the aortic valve is open, when the left ventricle forces the aortic valve open, then however high the pressure gets in the left ventricle, that's how high the pressure will get in the aorta, because it's literally just ejecting the blood right into this next room. Now, when the aortic valve shuts, that creates the second heart sound, right? That's the dub. And the pressure in this room, this ventricle, drops precipitously all the way down to atmospheric. All the way down. Notice that the pressure in the aorta, in that hallway, is only gradually dropping. Now, if the ventricle, if everything's normal, this ventricle is going to relax, refill up with blood, and then it's going to generate pressure and eject more blood, raising that pressure in the aorta from a low of about 75 or 80 back up to 120. So it means that normally the blood pressure in the aorta reaches a high of whatever the left ventricle reaches, 120, and then it will go down to about 75 or 80. And then the ventricle ejects more blood and it raises it back up to 120 again. So typically blood pressures in the aorta and all of the major arteries branching off the aorta are about 120 over 80. But what would happen if that ventricle stopped working? If the ventricle stopped working right after it had ejected blood, right here, the pressure in the aorta would go down slowly. It would be dropping slowly, but the pressure would be dropping and heading towards zero. If this were a medical show, if this was a TV, Grey's Anatomy, ER episode, this is where the nurse might, for example, might be saying, the pressure's dropping. We're losing the patient. And this is where they would pull out maybe a defibrillator, if that's possibly the heart has gone into cardiac arrest because of fibrillation. Now, it could be if gone into cardiac arrest, not because of fibrillation, but the heart simply stopped working. Then they would inject, they give them IV injection, bolus injection of adrenaline, epinephrine, and also atropine. They give them a sympathomimetic and a parasympatholytic to try to get that heart working. If the reason why the heart is stopped, because it's literally fibrillating and quivering, then they've got to defib. That's where they go and pull out the paddles, and they say, charge, clear, and they put it on the chest, and they're trying to shock the heart to start working. If they can't get that heart to start pumping, the blood pressure is dropping. And as the blood pressure is dropping, it is the blood pressure that forces the blood through the vessels of the body, including up to the brain. So as the blood pressure is dropping, blood flow to the brain is dropping. And if blood flow to the brain drops to zero for more than 4 minutes, you got brain death. So you've got those 4 minutes to get that heart start working again. Now they can do these mechanical compressions of the heart to try to get that, artificially move some blood, but they really have to get that pump working. So that's that blood pressure in the aorta. Let's summarize what we've been talking about, see what we actually wrote here. Let's go back to page 205, and on 205, this is page 205. At the top it says events in the cardiac cycle, systole. Now we have divided systole into 2 phases, isovolumetric contraction phase and ejection phase. At the time that the ventricles start to contract, there's about 120 milliliters of blood in each ventricle. We wrote that as the ventricles begin to contract, the intraventricular pressure rises. It increases, forcing that AV valve shut, right? As the pressure in this room increases, the blood tries to go backwards, and if that valve is working properly, that effectively closes that valve, creating the first heart sound, the lub sound. All right? So now, both the inlet valve and the outlet valves are shut during isovolumetric contraction phase. This is just showing this increasing in pressure in the left ventricle. Now, the ejection phase. The ejection of blood begins as the intraventricular pressure. You'd say, what's that? The pressure in the ventricle. When the pressure in the ventricle exceeds, you'd say, what does that mean? Becomes greater than the pressure in the artery. You'd say, what artery? The aorta. The left ventricle ejects the blood out into an artery called the aorta. In order to push this door open, it's got to push against whatever the blood pressure is in the aorta. So normally the lowest the blood pressure gets in the aorta is about 75 or 80. When the left ventricle generates more than 75 or 80 millimeters of mercury, it pushes that door open. And it begins the ejection of blood, which is shown right here. If we were talking about the right ventricle instead of the left ventricle, the right ventricle ejects the blood out into the pulmonary artery, and so it forces the pulmonary valve open, ejecting the blood into the pulmonary artery. You might remember what I said last week. One of the major obstacles to understanding the physiology of the heart is many of us still can't remember the order in which blood flows through the heart. You've got to memorize it. If you're still saying, I don't know, right ventricle, let's see, blood goes from the right ventricle to the what, left atrium? No, that's the pulmonary vein? No, that's not right. If you don't know where the blood goes next, then every time I say these words, you don't know what I'm saying. Because you're still stumbling around not knowing what these words mean. You've got to memorize the order in which blood flows through the heart. I'm telling you, it's not complicated, but until you've got it down, backwards, forwards, and sideways, then you can follow a whole discussion on this. But otherwise, if I'm saying that the right ventricle is ejecting blood past the pulmonary artery, past the pulmonary valve into the pulmonary artery, and the left ventricle is ejecting blood past the aortic valve into the aorta, you just got to know that. Otherwise, you're not sure what I'm saying. Let me try to... I mentioned that the pressure in the left ventricle has to exceed. It has to be greater than whatever the pressure is. Let's see. It has to exceed the blood pressure in the aorta. Let's try to demonstrate this. What I'd like to do is, let me just get... all right, let's see. We'll get, all right, we'll get Ellie and Dan, you're here. Colin, why don't you just come, three guys, just come right here. All right, and the three of you guys are going to represent, we're going to do this a couple of times. I'm going to do this again later. Just come over here. You're going to represent the strength and power of the left ventricle. All right? All right, and I'm going to be the pressure on the other side of the door. The pressure on the other side of the door is the blood pressure in the aorta. All right? So just, I'm going to be, now, what did we say? We said normally, by time the left ventricle is generating, raising pressure, right? It's contracting, building up pressure. It's pushing against this door, against the pressure in the aorta, which is about 75 or 80. All right, so go ahead and you push against this door. All I have to do is push. I got the door open. Go ahead and push. Push. Good. But very good. All right, no problem, right? All right, you had to work against that pressure on the other side of the door. Now, later today, we're going to show you what happens when somebody has systemic hypertension. Because when they have abnormally high blood pressure in their aorta and systemic arteries, the left ventricle has to work a lot harder to get the damn door open. And that's why high blood pressure puts an increased workload on the left ventricle. We'll get to that. So thank you very much. We'll use the same guys a little bit later. All right, so now on page 207, on 207, okay, on 207, we wrote that the pressure in the left ventricle and the aorta, because when that aortic valve is open, whatever the pressure is in the left ventricle, that's what the pressure is in the aorta, peaks at about 120. Now, the next point is very important. Have you ever heard of taking somebody's pulse? Now, what are you trying to determine when you take somebody's pulse? Their heart rate. Their heart rate, right? You feel a pulse. You are not trying to determine their blood pressure. You are trying to determine their heart rate. You cannot feel blood pressure with your finger. If you could feel blood pressure with your finger, you wouldn't need this. You'd say, I have magic fingers. I will tell you whether you have high blood pressure or not. You cannot feel blood pressure. If you feel an artery or you feel a vein, you don't feel any difference in pressure. you have to measure it, either directly with a catheter or indirectly with a cuff. All right? You were feeling a vibration wave in an artery. In an artery, you can feel a vibration wave created every time the left ventricle powerfully ejects blood. When the left ventricle powerfully forces the aortic valve open and it starts to eject blood, it causes a vibration wave in the aorta and all of the systemic arteries that branch off the aorta. And you are feeling a vibration wave called a pulse. That is not a blood pressure. That's a vibration wave created by a rapid ejection of blood from the left ventricle. There is no pulse in a vein. There is a blood pressure in a vein, but there's no vibration wave. So if you felt that you've got magic fingers and can feel blood pressure, you should be able to feel pressure in a vein. You will feel nothing. What you are feeling is a vibration wave called a pulse. Is everybody clear on that? Because you can bet I'm going to ask you about that.
That's the heart rate?
That's the heart rate. So, that's exactly what we wrote here, is a vibration wave generated by the rapid ejection of blood by the ventricle. This vibration can be palpated or felt along all the arteries of the body, which is how you differentiate an artery from a vein, by that pulse. You don't feel a pulse in a vein. Okay, it's a vibration wave that makes the arteries vibrate, but it is not transmitted to the capillaries or the veins downstream from the arteries. Make sure you understand that. All right, now, we know that the ventricle, each ventricle is going to eject a stroke volume of about 70 milliliters of blood. It filled to 120, it ejects 70. With every stroke of my heart, it ejects 70 right at you, and leaving 50 still remaining in each ventricle. Okay, and so the amount ejected is called the stroke volume. Now, diastole. Diastole is the period when the ventricles relax. We have now divided diastole into two phases, just as we had divided systole into two phases. Isovolumetric relaxation phase and filling phase of diastole. As the ventricles begin to relax, the semilunar valves shut. You'd say, what the hell are those? That's the pulmonary valve and the aortic valve, the outlet valves. They shut. And when they shut, that creates the second heart sound, the duct. None of this is difficult, but you've got to walk your way through it. And I would suggest you get together in a study group and you literally say it over to one another to the point where you feel you understand what that heart is doing, step by step. We're talking about at least the second most important organ in the body. Better you shouldn't know anything about a gallbladder. You can forget a gallbladder, a spleen, and one of the kidneys, and a number of other parts of the body. You got to know the heart. You're going to be in the healthcare field. You got to know the heart. It's to say, I know all the organs except the heart. Don't go into the field.
Yeah, the heart is hard.
All right, now, so during isovolumetric relaxation phase, just like isovolumetric contraction phase, all the valves are shut. That's why it's isovolumetric. No blood's going in, no blood's going out. The pressure during this time drops all the way down to 0. You'd say, what does 0 mean? Atmospheric. Now, the filling phase, as the pressure in the ventricles becomes less than in the atria, don't confuse an atrium with an artery or an aorta. Okay, the blood in the atria force the AV valves open, and the ventricles fill back up to 120. They add 70 milliliters of blood, raising their volume back up to 120. Now, in fact, there's commonly such rapid filling of the blood as that all that blood that had accumulated in their atrium while the ventricles were busy contracting, when that AV valve opens, it just rushes into the ventricle, and it can create, especially in children, a murmur, just because of the rapid refilling of the ventricle with blood. This is found not uncommonly in children. Doctors are aware of that. And usually it goes away as their heart grows bigger, as the person grows older. So if you've ever heard of a child where they detected a murmur, this was on all probability what the murmur was, and the pediatrician probably said, we want to watch it. Don't worry about it. And in fact, it went away as the person grew bigger, their heart grew bigger, and that characteristic rapid filling of the blood during filling phase of diastole, that murmur went away. Now, during this time, when the ventricle is refilling, the pressure in the aorta is dropping, as well as the pressure in the pulmonary artery. But that's okay. The ventricle is going to recontract and re-eject blood. Now, let's look at page 208. And 208 is a really cute diagram. Because on page 208, this is showing, on the x-axis, the pressure in the left ventricle in milliliters. On the y-axis, the pressure, not the volume, right? X-axis is the volume, in case I didn't say that right, the volume in the left ventricle. On the y-axis, the pressure in the left ventricle. Now, this, in this loop, it has both numbers and letters. The numbers are the 4 phases in the cardiac cycle. The 4 phases in the cardiac cycle. The letters are either where the valves are opening or closing. So whenever a valve either closes or opens, that's indicated by a letter. So let's just show you how we read this. Let's look at point A. At point A, what is the volume of blood in the left ventricle? It's trying to show it's about 120, approximately. 120 milliliters of blood in the left ventricle. We read the volume here. What is the pressure? The pressure is just a little bit above 0, just a little bit above atmospheric. Now, let's look at phase 1. Notice I've tried to help you by drawing arrows. This is phase 1. Now, in phase 1, you'd say, which phase is that? You're going to tell me. In this phase, what is happening to the pressure? It's increasing. It's going from about 0 up to about, right, 70, 75, something like that. It's increasing. What's happening to the volume during this phase 1? It stays the same. It's 120 here. It's still 120 here. You read the volume on this x-axis. The volume didn't change. So what phase is it? Isovolumetric contraction phase. It has to be isovolumetric. The volume stayed the same, and the pressure is rising. That's isovolumetric contraction phase. Let's look at phase 2. In phase 2, the pressure continues to go up. From 70, it goes up to about 120, between point B and point C. So the pressure went up. What happened to the volume? The volume at point B was 120. The volume at C is what? 50. So the volume decreased by how much? It was 120 here. It's 50 here. Everybody's getting really good at graphs. I promise that. By the end of this course, I said everybody's going to know how to read graphs, because we use graphs all over the place in physiology. So the volume decreased by 70. All right? The pressure did continue to go up. What phase is this? Ejection phase. During the ejection phase, the pressure still rises from about 75, 80 up to 120, but the volume in the ventricle goes down as it ejects the blood. So, what valve opened or closed at point B? What happened at point B in terms of a valve change? A valve opening or closing? What has to happen to go from isovolumetric contraction phase to ejection phase? A valve, which valve opened? The aortic valve. So at point B, the aortic valve opened, and that allowed the ejection of blood. I'll let you, with your study group, walk through the rest of this so you understand the 4 phases and the opening and closing of valves, as indicated in points A, B, C, and D. Now, on the bottom of page 208, we were talking about the left ventricle for the first half of the class today. And I want to compare and contrast the right ventricle with the left ventricle. In this graph, this is just showing, this is time going by on the x-axis, and here it shows pressure in millimeters of mercury. Let's start with the left ventricle. So in the left ventricle, the pressure ranges from a low of about 0 atmospheric to a high of about 120. So how would we write that? We would literally write that the pressure in the left ventricle is 120 over 0. Because when the ventricle contracts, and what do we call that period where the ventricles contract? Systole. So the pressure rises, and that's called the systolic high. And when the ventricle relaxes, it drops all the way down to atmospheric. Notice also, here the dashed line, just like that big graph we had seen earlier on page 206 before the break, here's the blood pressure in the aorta, and it goes, remember, once the aortic valve is open, whatever the blood pressure is in the left ventricle, that's exactly what the blood pressure is in the aorta. And so it reaches a high of 120. When the aortic valve shuts, the pressure in the left ventricle drops rapidly to 0. The pressure in the aorta starts to fall gradually. And it typically falls to about a low of 75 or 80. And by the time it reaches 75 or 80, the left ventricle has recycled, and it's ready to eject more blood out into the aorta and raise the pressure back up to 120. So what's the typical blood pressure in the aorta and the systemic arteries branching off it? 120 over 75, 120 over 80. So that's why when you estimate the blood pressure in the brachial artery using that cuff and the auscultatory method, a normal blood pressure is approximately 120 over 75, 120 over 80. That's the pressure in the brachial artery. It's a little bit lower than it is in the aorta, because if you could remember from your anatomy, what branches off the aorta is a subclavian artery, and then it goes under the clavicle, and when it reaches the armpit, it's called the axillary artery, and by the time it reaches the upper arm, it's called the brachial artery. So you're estimating the blood pressure in the brachial artery, which is just a little bit lower than what it would be in the actual aorta. Now, in contrast, the pressures in the right ventricle are about 1/6 as high as they are in the left ventricle. Why aren't the pressures in the right ventricle as high? Because the right ventricle only has to develop a strong enough pressure to push the blood through the lungs, the pulmonary circuit. The left ventricle has to generate a much higher pressure to push the blood all the way up to your head and down to your feet and back through the entire body. So what is the normal blood pressure in the right ventricle? It goes from a low of 0 to a high of about 25 over 0. We had mentioned this the other day when we talked about putting a catheter into the right atrium, right ventricle, and pulmonary artery. In the dashed line, it shows the blood pressure in the pulmonary artery. The right ventricle ejects the blood out of the pulmonary artery. When the pulmonary valve is open, just like when the aortic valve is open, whatever the blood pressure is in the right ventricle, that's what the blood pressure will be in the pulmonary artery. So the pressure in the pulmonary artery reaches a high of 25, created by the right ventricle, and it starts to fall, and it reaches a low of about 10, really closer to 8, but we'll say 10, and by the time it reaches 10, the right ventricle is ejecting blood out into the pulmonary artery, raising the pressure back up to 25. So those are the normal blood pressures.